Hi, my name is Brett Levine, and I am here today with the American Association for Hip and Knee Surgeons as part of our patient advisory group. We have Arthur Caplan with us today. This is Dr. Caplan, who is the professor at NYU of bioethics. He is the Dr. William F. and Virginia Conley Mitty Professor of Bioethics in the Department of Population Health. He's published more than 800 peer-reviewed articles and 35 books. We're going to discuss today his journey through a joint replacement, as well as some of his feelings and opinions on some of the current health policy issues ongoing within joint replacement at this time. So I'll start with my first question for Dr. Caplan. How did you choose your career path as a professor in bioethics?
Found it engaging and wound up deciding to do a double major of biology and philosophy. Later, I decided to go to Columbia Med School, and I went there for a while, and I saw all kinds of interesting ethics issues coming up. At the time I was there, we didn't have enough dialysis machines. We were fighting about who should get them. We were deciding whether or not in vitro fertilization, making babies in test tubes, was permissible. Some people thought we shouldn't try to make human beings outside the body, although eventually it became Louise Brown and then probably hundreds of thousands of more children born that way, and many, many ethics questions. And so I picked up my interest in ethics, went to the dean of students at Columbia and said, I think I want to get a degree in philosophy and study some of these ethical issues in medicine. And he said, I'm not sure what you're talking about, but okay, you try it. I'll back you up. And so I wound up getting a PhD in philosophy. And long story short, I never went back and finished because I got so engaged in all the ethics activities that I didn't finish up my med school thing, which made my mother, to her dying day, very angry. She kept asking me, when are you going to finish your doctor? You become a real doctor. But well, that's Jewish mothers. What can I tell you?
Very nice. How did your path wind up at NYU?
So I wound up where I am today, where I've been for 9 years, because I worked at the University of Pennsylvania for 20 years. And the individual who was selected to be the dean of the NYU Med School decided to move up there, and he recruited a bunch of people that had worked with him, including me, to go with him. That's the sort of cover story. The other main reason is my wife got offered the directorship of the Bronx VA hospital. She became the CEO, and she'd followed me around for a lot of jobs. So I sort of thought, well, it's time for me to follow her at a job. And so we came up to New York.
Totally understand that one. Well, with your busy schedule, how do you find time to help us and participate in this patient advisory group?
Well, I have been interested in orthopedics and some of the ethical issues there for a long time. I've also had knee replacement surgery, so I'm a patient and I got interested in that. But I think orthopedics is a neglected area in the ethics discussion. Sometimes people just think, well, what are the issues there? They replace parts and deal with things. You look at the whole field from sports injuries. There are many, many tough questions about how you're going to talk to parents about overuse in pitching or some other kind of misuse of the kid in order to try and get them maybe to get a college scholarship. If you look at straight up orthopedics in terms of discussions about what joint to use or how you explain to people what they may need to do in order to get the maximum result from their joint replacement, how far can you push them, how much can you expect, what's ethical, in other words, to ask a patient and their caregivers to do, and cost issues are clearly there. So I think I've been interested in it for some time. And I have to say at NYU, the orthopedics department has been receptive to talking about ethics issues. We have a faculty member in there who works on the issues and is cross-appointed to our medical ethics group. So it's been a pretty fruitful area for thinking.
Fantastic. And a little bit more about your joint replacement. How'd you know that you were kind of ready for a joint replacement? What kind of clued you in that this was the right time?
So for me, my right knee had been bugging me. It's an argument, by the way, against playing football because I know that joint got pounded around a lot in sports, and it wasn't just aging, although probably contributed to that. But I began to have a lot of pain walking. I was finding it harder to get upstairs. I didn't have any falls, but I knew going all the way back to my med school days that something was bad in that joint. And I suspected it wasn't torn ligaments or anything like that. I thought, well, you're 71 years old. You got a beat up knee. You're having trouble putting pressure on it. You can't do the stairs very well. You can't really get around very well. You sound, Art, like a straight up candidate for at least getting your knee looked at. So I went in, I had an x-rayed, not to put down Dr. Levine, any of the skills of orthopedists, but I took one look at that x-ray and said, that's a knee replacement. That joint is mashing together and there's no cartilage in there. So I knew, and I didn't hesitate at all. I know people worry. I mean, if I was going to give one bit of advice, I think it's always better to go earlier than later. You have, more damage the longer you wait. So I was a little happy that I went when I did.
Great. Yeah. So, sometimes we definitely don't profess to be brain surgeons when we look at those x-rays. Sometimes they are pretty obvious. Did you have any help? I know obviously you work at NYU, and I know a lot of the faculty there, a bunch of great people. Any help or ways that you kind of decided on the surgeon that you wanted to go see?
Well, I knew a lot of the docs, and I also knew just from remember we'd had prior contact with the department, thinking about some of the ethical issues, that we had a very good knee surgeon, a guy named Richard Iorio, and he and I hit it off. We'd been friendly. We're both from the Boston area. We like to rib each other a lot. I trusted him when he said, the only thing that was bizarre, to tell you the truth, and I'll put this on tape, is it was pretty clear to me that he needed a knee replacement and wasn't moving so fast toward it. So we're about the same age, and I was sort of watching his gait and thinking, we're going to not do what I say, but you got to do what you got to do, kind of thing. Anyway, he subsequently has had the same surgery, but it was really a bond between that individual doctor and me. I knew he was good, and I trusted him, and he explained things very clearly. I knew what was going to happen. Pretty a good, strong, informed consent. I felt I understand the risks. I get the benefits. I see what's going on here. I'm going to make that choice.
And as far as timing goes, what kind of made that the right time? How much time did you feel like you needed to clear from your schedule so that you could adequately recover?
Yeah, I did it in the summer. It's a little slower for me in terms of academia. It doesn't stop, but it's a little bit slower. I knew I could probably stay home. It was pre-COVID, just pre-COVID. So I also knew that I could use Zoom. I didn't know how much I was going to be using Zoom to supplement work, but it's funny. I'm a pretty bad patient when it comes to work. So I would say within a couple of hours after waking up from surgery, I was checking my emails, starting to answer issues that were coming up at the school or the division or patient problems. And I'm lucky. I don't have manual labor. I don't have to lug bricks or do some sort of tough physical work. My work is done mainly from chairs or lecterns and that sort of thing. So I left time, and I figured I could get pretty mobile after 2 months, 3 months. I'd be kind of as recovered as I was going to be. And then I'd keep at it. I knew it wasn't just going to be a 3-month recovery, but I thought the bulk of that time, I'll do it over the summer. And by the way, I should add a funny note. Dr. Iorio was getting problems for me because his wife very much wanted to return to Boston, and he wound up getting a job offer up there and became head of the knee and joint replacement service up at Brigham, and I was his last patient. But I gave him a really hard time for abandoning me. He fled right after he did me.
Well, that kind of sounds like Rich. Uh, as you look back on your experience, any advice you'd have for patients?
Yeah, I would say a few things. One, I hear people try to do this without really arranging help. You need help in the initial recovery period. I think the danger of falls is there. And then just to get around initially, I'm talking about the first couple of weeks, it can be tough. Not so much because it's painful and horrible. It's just you don't have your balance. You don't have your muscles are getting a little atrophied from all that's going on. So I would absolutely make sure I had a helper, spouse, relative, hired help, somebody. I was lucky in New York City. It's a very good visiting nurse program, and they came in and helped, and I would be looking to make sure I knew what I had available for me for that. I'd say two other things, probably getting up, when they told me right after the surgery, we're going to have you up and moving, I don't know, within 10 minutes after you wake up from anesthesia, whatever it was a short period of time. I thought, this is crazy, but it really is true. You got to move, you got to participate. Your rehab is as crucial as the surgery. I really believe that. You've got to be ready to put some time into that. Then the other thing I would say is, have reasonable expectations. I didn't get back all the mobility I hoped for. My joint was pretty damaged. It's much better than it was, and I could do more than I could. But, when you got to know where you're starting from to where you hope to get to. And that's just, plus, because of age, I have some other issues with my back. So I'm not running marathons, but I have enough mobility now to keep me satisfied that I can, get where I want to go on a vacation, do things I couldn't do before. But you got to be reasonable in terms of what you're thinking about.
Yeah, those are excellent points. I think sometimes we lose sight of that sometimes people think they get a new knee and they're going to be 20 years old again, and
Right.
forget about the other issues ongoing, and the fact that the knee
Right. I can assure you, in a 71-year-old body that's, pretty relatively healthy, things are aging. Let's put it that way. You're not going to fix all of that by getting a knee replacement.
Fantastic. So we're going to switch gears a little bit, and we'll try to keep like all the political affiliations and stuff aside. But what are some of the challenges that you see facing joint replacement surgeons, patients, just medicine in general in the near future, with the pandemic and everything that's kind of going on with budgetary cuts?
I'll say two things that are important. One, I think people need to understand when COVID comes, resources get diverted there. You're pulling anesthesiologists over to help with COVID patients. You're tying up labs, all kinds of things are shifting. They certainly did in NYU hospitals when we had surges of COVID. And that really makes people think, well, I'm going to put aside other procedures like knee or hip or elbow or other joint replacement surgeries. They're elective. That's the common term. If you can't move, if you are bedbound, if you're in a lot of pain, it's not very elective. And so one thing I see is we have to come to understand, first, everybody should take responsibility for minimizing the impact of COVID. It isn't just whether you get sick. It's even if you get sick and you go to the hospital, you're taking resources away from other people that need them, even though it may not be a life and death situation. It's really important to be able to function. So get vaccinated. Make sure that you mask as much as you can. Do the things that will keep you out of the hospital so that other people can get services that they really need. It's not relative to knee replacement, but even putting off a colonoscopy because you don't want to go in there because it's full of COVID or they don't have the services, that can lead to deaths because you don't find cancers early and so on. So I don't buy this, that's elective, it's just orthopedics. And over here is, well, that's important, that's the ICU. And we get, it's very important when you're not able to ambulate, when you've lost functions, can't take care of yourself if you live alone, that sort of thing. The other big lesson I would draw here is in terms of resources, efforts are underway to try and contain costs. I'm not against containing costs. Who could be? That's a nice goal. We're all for that. But we don't want to chop reimbursement levels down to the point where it impacts care. And that's what is going on in orthopedics. That's what has my attention. I know when I had my surgery, there was a certain fee set. The orthopedist got paid whatever it was, and they had set up pretty efficiently, knowing what the reimbursement was. They could move patients through at my particular place rapidly. But there are a bunch of ancillary services that are crucial to making this kind of surgery work. Before, you want to make sure you're losing weight if you're obese, or you want to make sure your diabetes is controlled, or you want to make sure that you've lined up your home services or that the visiting nurses are coming. And you start to wonder, this isn't just a surgeon with a knife, it's a package of services. And who's paying for that under the reimbursement? After surgery, you do need rehab. You're going to need PT. You're going to have perhaps other services provided to you for a while. Who's paying for that? So I worry that if you just said, well, it costs X to do the surgery, and that's what we pay, you're going to be making the procedures less efficacious. They're not going to come out as well because you're not really paying for the package of services that you need.
Yeah, certainly with the budgetary cuts that have been proposed, we can see that we've worked on our bundle payments, and we've decreased some of the access to some of those resources, trying to keep those bundles down. Fortunately, they just delayed again some of the budgetary cuts for Medicare and Medicaid. But this probably fits kind of right into your wheelhouse, the ethical issues of if they keep cutting, surgeons dropping out of Medicare and no longer taking care of Medicare patients. Do you see any concerns as far as access goes to some of the bigger academic institutions and some of the so-called top docs dropping out of Medicare?
I really worry that access could be hindered if cuts are made that really are damaging, just not fair to what it actually costs to deliver services. And that's true for Medicare patients in particular, who constitute a pretty big proportion for many places of the people who need these services. Look, you're not going to run an orthopedics place, generally speaking, by getting rid of all your Medicare patients. I don't even know if that's fiscally viable. But some people are going to start to say, some of the better people, I can't do this properly at that rate, and I'm not taking those patients. That's what's going on. And then that, if it happens in an area, I'll just make this up, in the state like Minnesota, Wisconsin, Iowa, you may not have that many choices. If somebody drops out and says, I'm not taking Medicare, and the bulk of those patients are passed on to other orthopedic docs, they can't necessarily handle the load. That means long wait times. That means more suffering, more pain, more inability to be mobile, that sort of thing. So I do worry about what would happen if Medicare patients in particular found themselves unable to access all surgical services.
Yeah, you certainly bring up a good point. I mean, in places like Manhattan or Chicago, where I'm at, there's lots and lots of physicians, but certainly in the more rural areas, the access to care concerns can be a big problem. Speaking of something along those lines, with the pandemic, we've seen a surgence of outpatient procedures. So now hip and knee replacements are being done on an outpatient. I'm not sure how long you stayed in the hospital for your procedure, but also along the lines of the ethical considerations, what do you think about telling the majority of patients that, look, this surgery should be done as an outpatient? You have to go home on the day of surgery.
Look, I'm not opposed to getting people out of hospitals. I've been around hospitals a long time. They can be dangerous places, a lot of infection, not necessarily nurse coverage all the time. There are issues, I get it. But the bottom line is very simple here morally. Decisions about what's best for the patient should be driven by doctors, their doctors' decision about what they need. If they think you can go home, great. But they shouldn't be thinking he's got to go home because reimbursement only lets me keep 3% of patients in, and I can't do it even though I'd like to do it. So if the decision is fueled by money and somebody's saying, we just can't hold you here because it's going to be too expensive for another night in the hospital, it's not paid for unless you want to pay for it. That's really bad. It's not the right way to practice medicine. The question is, what's the best outcome for each individual patient in terms of their access to time in the hospital and what they need? Just throwing everybody out, because there isn't enough reimbursement. That's economics driven. That's having an economist be your doctor. And that's not the right way to do it.
More and more nowadays.
Let me slug this.
More and more nowadays, it seems like that a lot of those decisions are economically driven, and that we are telling patients you have a day or at most within the hospital, and then having to justify why people stay. So the big concern from the hospitals is that the reimbursement is different if it's considered an outpatient or an inpatient procedure. And so with the removal of the hip and knee replacements from the inpatient only list, now everything is getting coded as an outpatient, and then it falls upon the physicians and their offices to prove that the person actually needed to stay.
Right, it's a key point. Just to be clear, what that means is the presumption is you're leaving. The doctor has to make the case why you're staying. I want the doctor to be free, whatever the reimbursement scheme is, to say Art needs to stay another night. I'm not sure he's ready to go home for whatever reason, or we can't send him home yet because his caregiver was sick or whatever, or maybe he got infected and we don't want to let him go because he had something else going on. That decision should be driven by the doctor. The first principle that all hospitals in reimbursement should honor is what the doctor thinks is best. Now, I'm not saying you can't measure it and test it and make sure that, we can do studies and establish who's likely. I went home pretty quickly. You can do studies and say, oh, X, Y, and Z, they kept them an extra night. They didn't need to. We'll shift them over to a category of earlier release. But let's be, if you will, driven or fueled by evidence, not by money.
I know those are all good points, which is what our fear is, that the guidelines for this sometimes are not generated by physicians themselves. And then, as we mentioned before, orthopedists are not rocket scientists or brain surgeons. And so our ability to, or I don't know if it's ability or desire or what it is to document all the medical comorbidities and all the treatment that's involved with a patient to justify an increased length of stay is maybe not the best. So, that's our concern, is where do those metrics come from? And, it doesn't seem to be coming from medical doctors. It seems to be coming down from Medicare or insurance companies.
So just to follow up on that point, oddly enough, orthopedic procedures have more data than most procedures. I mean, I spent a lot of my time in medical ethics thinking about things like transplants. And ironically, they have pretty good data too. You can see when the procedure happens, the outcomes pretty clearly. You don't have to argue about it. They're alive, they're dead. You kind of know what's going on. And you can see where complications occur, where repeat admissions happen, that sort of stuff. Orthopedics has some of the same thing. When they're coming back, whether they're walking a mile by a year out or whatever targets you want to set, the infection rates, what happens if people go home at time X as opposed to time Y. It's not that we couldn't pull the data. The pressure is on so strongly to cut costs that I think people are shortcutting data. So I'll disagree with you a little bit. I think we could do better just analyzing databases and stuff that's out there already. I mean, maybe the orthopedic doc individual one doesn't want to do that, but the data's out there. It's not like you can't do it in fuzzy areas, psychotherapy, or are you improving somewhat from having a regimen of exercise after asthma? That may be tougher to figure out what's going on, but I don't think that's so true in orthopedics. I think we could be data driven. That just may not be where the zeitgeist is these days about what we need to do about cost.
Yeah, the cost seems to be the big issue, because doing research obviously costs money. Collecting that data costs money and time, and then that's where things have kind of, like you said, could definitely be better. Um, on all fronts, it's just a matter of who's going to fund the studies and who's gonna put the time in. And it seems like as cuts keep coming, we keep ramping up volume, which then puts less and less time in there for doing all the research that probably needs to
Right.
be.
Like I will say, the day I had my surgery a couple of years ago now, I was amazed at the efficiency of what was going on. I mean, I went in, had my knee replaced. If it took 45 minutes, it was a long time. I don't know. It was rapid. I'm talking about the actual replacement of the knee. Boom, someone was in right after me. You can see all the equipment and devices lined up. Everybody's in their moon suits. It's a very efficient process. It's not like people are sitting around having a cup of coffee between patients or something. They're at a big center like NYU, and I'm sure it's true at your place. They're in there, bang, bang, bang. So it's not like inefficiency is driving the surgical side. I don't believe that. The fight is, do you want to pay to get best outcome? The fight is, do you want to use data and analyze it to determine, what's the best use of these resources? But I think the surgery side has been made very, very efficient. It doesn't seem to me it's full of waste or people dawdling around or something like that.
Sure, that's been the sort of the jab that we feel like we've taken recently, is that it has become very efficient. We have worked very hard in that. We've trimmed the fat on the sides the best we can, and then the even though expenditures for Medicare and orthopedics was down this past year, the proposal was to cut us 10% for hip and knee replacement reimbursement. So it seems like we're doing a lot of work to help out in Medicare, and then the reward for that is to then get cut. So it's, why put the effort and the time into more research if it's just leading to more cuts. So that's where
I think it's interesting too. Sometimes you may have a system which says, be more evidence-based, and as you are, we'll reward you with something. What happens too often, I think, in orthopedics is, as you're saying, there's a penalty. Oh, look at that. Now we could do this, if we kicked everybody out within 10 minutes of surgery, or we don't need the same staffing available when we're doing the surgery, or maybe they don't need as much PT after. And maybe it all turns out to be true, but the reward is, well, then you just get less money and let's go on. You have to find ways to reward the efficiencies, to reward better outcomes. You don't just do it with a crude, axe and then wind up harming the quality of care. And and I'm sure some people watching this are thinking, really, you want me to have sympathy for orthopedic surgeons? They seem to live in nice houses and drive around in nice cars. I think those people should get paid. I think they do important work. I'm not arguing that all salaries in healthcare are where they are, but look, it takes a long time to train. I can tell you this, audience, it's a long time to become a orthopedic surgeon. I've watched the residency programs, fellowship programs, and so on. There's a lot of debt. There's a lot of training. I don't begrudge people money when they're doing important work. I don't worry about what my cardiac surgeon is getting paid. I see the transplant guys are getting paid, but they work hard. And my argument would be they deserve it if they can show good outcomes. So this isn't a fight about, oh, let's shed tears for doctors and their payments. It's really a fight about, are you going to hack the reimbursement down to the level where they're working at a rate that they don't think is safe, or you're going home sometimes as a patient when they wouldn't do that, or the pressure to maintain volume tires out the teams. I'm always thinking, again, patients don't think about this. You might pick the best doc there is, but if you're at the end of the surgery schedule and they had to do 7 instead of 6 in a day, are they going to be at the same level of quality sharpness because we said do more to make the same amount of money?
Yeah, that's where I think most people won't be bleeding for our salaries, and our salaries are pretty good, but it's mostly because we have done that ramp up in volume, and it is concerning for the longevity of a person's career to be doing that many surgeries in a day, and the safety for patients. So in the end, we're kind of more asking for, let's just keep it roughly the same. We didn't even ask for a raise. We're just saying let's stop cutting at the rate that they're cutting, so that it doesn't become to the point where there are 8, 10, 12 cases being done in a day, and then how does that patient feel as number 12 in a day?
Exactly. I'm aware of it when I talk to orthopedic colleagues and residents in particular who carry big loads in training institutions. They're starting between COVID and other things. They tire out. They get stressed out. As well routinized and as well understood as a knee replacement or a hip replacement might be, I don't want a stressed out, overtired doctor doing my operation. Not really what I want.
Yeah,
That's not what anybody watching this should want.
that's probably not the best thing to have is your surgeon coming in burnt out and tired and frustrated. So those are all fantastic points there. Anything else you have to add to for patients? This has been a great 30 minutes.
I think some people watching this may say, well, this is all a little boutique. I'm not getting my hip replaced. I'm 40 years old. What do I care about all this? Look, population's aging. There is going to be demand for this. We're getting better at joint replacement. I know that some procedures that might have been treated as maybe the outcomes aren't so great. I'm thinking shoulders and things like that here, tougher to do. They're getting better. I'm amazed, in fact, at how well the outcomes are from things like hip replacement. That's been around a while and people really get it. But my point is, we have to pay attention to this because you are likely to need it at some point if you're lucky enough to live long enough. Just wear and tear will probably put you in a situation where you're going to be considering something is going to need to be replaced because it wore out. Putting aside diseases or injuries or other things that might lead to demand. And then we have to pay attention here for a slightly different reason. Orthopedics and cost cutting and setting bundled rates, meaning one fee for all the services, this is a canary in the cave for the rest of the healthcare system. So if we're going to let reimbursement separate from evidence or not listen when doctors say you're cutting too much, you're causing us to ramp up, say, volume in a way that is compromising what we think is best care, that is something that could be a danger across the board in healthcare. So we want to pay attention here because this is where the battle is being fought.
Outstanding. Well, thanks for taking the time to chat today.
My pleasure.
And look forward to the group getting together again in the future, and your advice on other aspects of orthopedics in the for hip and knee replacement.
Very good.
All right.